Great. Awesome. All right. Welcome and good morning, everybody. Happy Tuesday. Thank you for joining us. We're excited to have you, and we're excited to provide you a technical assistance training this morning. So today we are doing addressing social determinants of health and to improve HIV care and enhance community resilience. I'm Elizabeth Probst, but I know a lot of you know that. I'm the community outreach coordinator for St. Jude, and I am here to introduce our speakers. That would be Sara Simon and Courtenay Sprague. So I will do introductions for both of our speakers, and then I will let them have the show. Also, please be mindful if you're not speaking or presenting, make sure that your cameras are off to reduce our bandwidth, and making sure that we give the bandwidth full attention to both Sara and Courtenay. So Sara Simon is an international development expert specialized in policy advocacy, specifically relating realities on the ground of policy development and implementation. She has extensive experience with underlying cause of poverty, human rights, and HIV. For the past 10 years, and she has been working on the role of multi-stakeholder partnerships in implementing the Sustainable Development Goals. Beginning her career in international development more than 25 years ago, she has worked on USAID and Europe-funded projects in the Middle East, Africa, and Asia. Most recently, she has been leading a technical assistance team for the European Commission's Policy Forum on Development since 2014. Sara has a BS in International Politics, and Arab Studies for Georgetown University, and an MA in International Economics and Middle Eastern Studies from Johns Hopkins School of Advanced International Studies, and a certificate in Humanitarian and Human Rights Law from the Institut International in France. She is a senior fellow at the Center for Peace and Democracy and Development at the University of Massachusetts, Boston, where she has carried out research in persons living with HIV to understand and share their experiences with health and healthcare insurance, stigma, and other social determinants of health. And then we also have Courtenay Sprague, a PhD and is an associate professor of global health at the University of Massachusetts, Boston. She holds a joint appointment in the Department of Conflict Resolution, Human Security, and Global Governance, McCormick Graduate School, and in the Department of Nursing, College of Nursing and Health Sciences. Professor Courtenay Sprague has over 18 years of experience of expertise designing and implementing field-based investigations among excluded people living with HIV and less resourced community and clinical settings in the southern U.S. and southern Africa. Her research investigates social determinants of health that influences people's opportunities to be healthy, with a key focus on identifying appropriate policies and interventions and to improve and support the holistic care of holistic health and well-being of people living with HIV. Courtenay holds master's degrees from Boston University and a PhD from University of Wits. I'm going to go with that.
Good job, Elizabeth.
In South Africa. And previously, she was an associate professor at Wits and has been working on HIV in South Africa with key partners since 2004. She holds a joint appointment with the Wits Reproductive Health and HIV Institute in South Africa, Faculty of Health Sciences. And again, I welcome both Courtenay and Sara. Thank you so much. And I'm going to turn it over to them.
Thank you so much, Elizabeth. Can everyone hear me okay? Can you give me a thumbs up if you can hear okay? Great. Okay. So we want to wish everyone a warm welcome this morning. Thank you so much for joining us. We know how busy everyone is, the work that you're doing, and the demands on your time. We want to thank especially Elizabeth, Katie, Chastity, and the other the others on the team at St. Jude. So thank you so much for allowing us this opportunity to engage with you. I'm going to begin with our learning objectives for today. Together, what we'd like to achieve is understanding what social determinants of health are, and that means defining social determinants. Secondly, explaining how social determinants of health function to influence the health and the well-being of those in our community and ourselves. Thirdly, describing material ways that we can all support the health of people living with HIV in our work by addressing these social determinants of health. And last but not least, beginning to unpack some concepts that are relational with social determinants, including health equity, human rights, and community resilience. So we're going to dig into those shortly. In order for this session to really have impact, it's important that all of you as participants think about what you could get out of this session. So you know the title of the talk, you know a little bit about the thrust, we've just shared the learning objectives, but what could you gain from this session today that would be of use to you in the work that you do? And so we're turning over a couple of questions to you, and you can either share these verbally or put them in the chat. The first question is, what is motivating you to do the work that you're doing? So that's the first question. Second question is, what do you hope to get out of this session that would be helpful? So any responses from our group? You can feel free to shout them out, or again, put these in the chat.
And please don't be shy, because
please
we are
don't be
really
shy.
hoping that you will interact. The session is
Yes.
set up very
Yes.
interactively. There will not be a quiz on Courtney's bio. Don't worry. At the end
Or
of the
Sarah's.
session.
Or yes.
Exactly.
And yeah, so I see, Sarah, do you want to read from the chat?
I would love to. I just have to find it.
Okay. We're new to WebEx, so.
And I can definitely be of support as well.
Okay, great.
Okay, I see is that Ali who's saying helping the community motivates me. And out of this session, wanting to get more, learn more about this subject.
Okay.
And Chastity, hi Chastity, who we've already had the honor of meeting.
Thank you, Chastity.
I do this work for a healthy community. Great. Thank you.
Great. Okay. All right. So, hello to everyone, and again, if you're just joining us, welcome. Okay.
Courtney.
What do you hope to get out of this session? What do you all think?
Yeah, I like Elizabeth just put as her motivation commitment to the greater good. I think that's going to resonate very much with some of the key concepts that we're going to talk about today.
Great, great.
Andrea is saying, yeah, being the change, right? Making a difference to be the change.
Wonderful.
Lovely.
Okay, any other additions? So as you're thinking about those, for yourselves, Sara and I, our work is motivated by a common interest and commitment to social justice and health equity in the work, that we do together. And we have been working together since 2012, and we've had a particular focus on HIV in the southern US and also in sub-Saharan Africa. So thank you for being a co-pilot, Sara, on this journey. Okay, so the people that we work with make it matter most. All right, this is our game plan for today. I'm just going to flash on this slide to let you know what's coming up. And what I want to do is headline a few key messages that we're going to be sharing with you as we proceed through the journey of this conversation today. And we'll circle back to these at the end. But What we're conveying to you through the research and through the data that we're unpacking together, through the challenges that people living with HIV face, is a set of key messages. First, social determinants of health, they typically include a range of structural determinants like socioeconomic and political context, other intermediary determinants that interact with the health system, and social cohesion to shape health status and health outcomes. But another way of saying some of these determinants are employment, education, poverty. Secondly, as a society, we want and need to end HIV, to end this epidemic. We want and need to move beyond a biomedical approach that embraces a people-centered approach to promote social determinants of health in order to advance health equity. So third key message, Sara, turning it to you.
Thanks, Court. So the third key message we want to get across is that there are some things that benefit all of society, and those are called public goods. And we are pushing the idea that health should be viewed as a public good, and we'll talk a little bit more about that. And then the last key message I think will resonate with many of you because I've seen the word community already come up 3 times in the chat and in the discussion about what motivates you, and that is community resilience. And this is one approach in which we can address social determinants of health and strengthen health outcomes.
Great. So just flashing on this side to let you know, give you a preview of, again, what's coming up. All of us are locating our work within a current context, and it is an epidemic context that both today and historically in the last several decades has made it clear that for people who are living with HIV in certain geographic settings in the US, such as the US South, populations have higher morbidities and mortality, again, relative to other people living with HIV in the United States. And when we look to 9 southern states, people who are living with HIV in those states have the lowest rates of linkage and viral suppression nationally. And so when we look at these data over time, we see that these poor outcomes are concentrated in locations of poverty among African Americans and other groups, and they do represent health inequities. So just to highlight that a parallel or intersecting epidemic is COVID-19. And so some of the data that we see for HIV, where we have seen these health inequities associated with the HIV epidemic in these groups that I just talked about, we also see the same underlying issues with COVID-19, where those who are socially disadvantaged or living in conditions where social determinants of health do not support their health and well-being, there are poorer outcomes. So here we see 71% of COVID deaths in Shelby County, concentrated among African Americans. So different epidemic, some of the same patterns, right? So there are these underlying issues that are driven, or underlying social determinants that are determining how healthy people are able to be, what they're able to do in the world. And so when we talk about health inequities, it's helpful to define these. And these are not random or occasional disparities. These are entrenched systematic differences in health status among specific social groups. And we see in the data over time, as I've mentioned, with HIV in the US South, we regard these health inequities as unjust, unfair, and importantly, they're avoidable. They're associated with existing social disadvantage. And a very key message, if you take one thing away from today, the majority of these health inequities, they are in fact changeable, because social determinants of health are socially rooted, they're socially produced by society. So things like enabling policies, for housing, access to health care. These are social policies. These are created by society, education. And so we can change these health inequities that currently exist for people living with HIV and in relation, to other health conditions. So the key message here again is that because health inequities are driven by social determinants and by society, they are modifiable with the right policies and interventions. And they're not going to change overnight, but they will change over time with political will. So turning to these factors that were identified in the community EndHIV901 plan, we're seeing a range of aspects that were put forward in the plan. And when we look at this cluster, what are they? What do they have in common? They're all social determinants of health. So I want to locate into context the conversation that we're having about social determinants of health, which I believe you may think of these as barriers, to HIV care, to linkage, to viral suppression, for people living with HIV. When we look at the historical context for social determinants, there is before the WHO's Commission on Social Determinants and after. Before the WHO produced a commission published in 2008, most of our understanding about factors that affect and shape health status and health outcomes were biological in nature. And so we had this for HIV in particular, it's so striking, the biomedical paradigm was the dominant paradigm, right? Let's treat our way out of this epidemic. After this commission, the commission helped through massive research and efforts, this international commission helped us all understand that these social factors that we've been talking about, poverty, lack of housing, food insecurity, lack of social support, that these social factors actually change biologically, physiologically, people's health and their outcomes negatively. So rather than having a biological, emphasis on disease, this commission was very important in helping us understand that the drivers of disease and ill health are and can be social in nature, and that introduced the opportunity to really regard the real drivers of HIV infection that we see both in sub-Saharan Africa and the southern US. So what are these social determinants? When we look to the literature, we've been talking about them, but this is the definition that's used by the WHO. The conditions in which people are born, grow, work, live, and age, and then this wider set of forces and systems that shape the conditions of daily life. This commission, which paved the way for the work that we're doing, the conversation that we're having, and how we can understand the conditions in which people live more broadly as being, either enabling or disabling, is very important. And it connected social determinants of health to social justice. So when we look to the WHO Commission, this quote is very striking. Social justice is a matter of life and death. This quote captures how, access to healthcare and equity in health is a matter of justice, right? And so it helps us link some of our normative goals about caring for people's well-being, enabling them to live a life that they value with good health, and access to healthcare as part of that. It really connected issues of justice, to the evidence base of what's going on. Okay, I'm going to turn it over to Sara.
Okay, thank you, Courtney. I'm going to introduce 4 key concepts that are, of course, interrelated, but that are important when we're discussing social determinants of health. I realize that I can't see you all, so it's a challenge for the interactivity, but I'm going to ask some questions as I go, and please feel free to chime in, interrupt, stop me or comment. We're still on the first concept, Court. So health as a public good. It's
Sorry.
okay. No problem.
I'm
Are
going.
people familiar with a public good? Do you know what a public good is? Should I take silence as a yes or a no?
I'm not familiar.
Okay, so a public good is something that everyone benefits from, right? It's a collective resource. So it could be something like street lighting or infrastructure, or maybe education or emergency services. In many cases, it's something that your tax money has gone toward, for example. And as Courtney's talked about, we know that this strictly biomedical approach to health is not advancing health equity. And we saw that highlighted again, not only through HIV, but through COVID-19, and the importance of basically addressing social determinants. And this has led to kind of a renewed call for looking at health as a public good. And here, maybe I can share my own experience. I'm from Houston, Texas, so I grew up in Texas, but I've been living in Europe. I live in Brussels, Belgium, and I've been here for the last 20 years. And my experience here is very different, and the attitude toward healthcare is quite different. So where I live, health is seen as a public good. So that means everyone has a right to that. So for example, refugees and other migrants who are here are able to access preventive, not just emergency health services, but also preventive services for free or at low cost. It's not dependent on your legal status or documentation. So I think the point we wanted to make here is that seeing health as a public good goes a long way into making health and health outcomes more equitable for everyone. Is that clear? Or do you have any questions before I move to the second concept?
No, it's clear. Thank you.
Great, sure. Yeah, it's not something I think that is in a lot of public discourse, but it is one thing that has come up, this call to really look at health as a public good and ensure that it's accessible for everyone. Thanks, Courtney. The next key concept is looking at this through a human rights-based approach. Is everyone familiar with human rights? Yes. Okay. Elizabeth gave me yes. Ali. Okay. I mean, these are rights that you have because you're born, right? They're inherent rights. You don't have to live in a certain place to have these rights. You don't have to be a certain sex, race, nationality, speak a certain language, practice a certain religion to have these rights. They are rights that are fundamental to everyone because you're a human being. And these rights were laid out in international law in 1948 through the United Nations Declaration of Human Rights. I actually found my copy because it's something I use in my work, and I used to carry these around with me. So this is like the short, small, original Declaration of Human Rights from 1948 that lays out some fundamental rights. So, and I thought, oh, I must have this near my desk, and I did, which is quite funny. But so right now there is a core kind of a set of core instruments, we call them, that are different treaties with UN members that lay out our fundamental human rights. The point here is that having a human rights-based approach gives you a legal lever to fulfill your rights. And I think we want to emphasize the point here that access to health is not a favor, it is a right. It's not something that's supposed to be seen as an add-on, but it is a fundamental right. But of course, if you don't know that, you can't demand it, right? So this approach is tied in as well as seeing health as a public good in achieving health equity as a social goal. And that's our third key concept, the way these things come together. So Courtney's talked a little bit about inequities, but this is essentially how we address the structural unjust differences among groups of people. And this is one of the key concepts we want to impart. How do we do this, right? We do this in different ways, and one way is through our fourth key concept, which is community resilience. So I looked again at the chat, and I know that this is a big aspect because there were actually 4 comments already, I think, of the 7 that talked about the focus on community. So a resilient community would be able to use their own capacities and resources to mitigate shocks or things that change in their environment. Right? And we address social determinants of health to strengthen community resilience. We're going to talk more about community resilience in our discussion, but the point here is that this is a power that is positive, that, as Courtney said, these social determinants are changeable, and communities can do that themselves. And why do we look at the community level? Because this is where the local knowledge is, right? You are the ones who are equipped to make these changes. So these are the four concepts. I have just briefly introduced them. Of course, there's a larger discussion to be had and probably a technical assistance training on each of those concepts. So we didn't want to overwhelm, but we wanted to bring them up and then maybe just touch base for a minute and get your reactions. Like, what do you think about these concepts? And do they resonate with you? And you can note that in the chat, but I will also open the floor for a minute and take comments because we would really like to hear from you. The point is to relate this to your own work and see how you're thinking about these things.
Yeah, please feel free to unmute if you feel comfortable just answering these questions aloud. We do welcome that.
Yes.
Please. Is there anyone who wants to take the floor? Because I don't actually know how the raise hand. There is one. Okay.
Sure. In the fourth concept about community resilience against adverse situations and challenges, the last sentence said other challenges, but does that include historical factors, the reasons why a community may have problems in the first place? A pandemic is something that pops up, right? But a lot of communities are in the condition they are in because of historical impacts like redlining, lack of access to healthcare over time, things like that.
Exactly. Can you tell me your name because I can't see who's speaking and I don't want to be rude to you.
Sure, my name is Krista Wright Thayer.
Okay, hi, Krista. No, it's a great question. That's a really important question because one of the issues of community resilience is basically to address those structural factors. That's why we talk about addressing social determinants of health within that. And there is a concept within community resilience called everyday resilience that actually does build on this. It's not just, as you said, for a shock, which is a common way of thinking of it, for something that happened like an earthquake or a pandemic, but it is also looking at how a community responds to those structural injustices. Courtney,
Just to
did you want
add,
to add
I think
something?
it's such an important comment and slash question. It's really a statement by Krista. Yes, unless we recognize some of the historical context and inequities that have been created, like redlining is a good example, we won't be able to address these social determinants of health that can disable health for so many, not just people living with HIV, but of course we see that very pronounced. So housing, for example, fair housing is a major challenge, and without that, then it's difficult, for people to, shore up their well-being. And so we have a big emphasis on healthcare, I think, in HIV, and we don't want to take away from that, but we need to recognize that with these social determinants that they exist in the communities where people live, and they need emphasis, and this is where we need the enabling policies, for housing, for example. So these are absolutely part of the conversation, and they need to be looked at historically, not just in the present day, right? The policies that have created those adverse conditions, for people. Does that make sense? Yeah, go ahead, Sarah.
No, Courtney, just building on that for Krista, because I think it's important. One of the aspects of the approach of community resilience is transformation, and it is changing those underlying injustices. That's the idea. So using changes in environment then to fundamentally shift within your community.
But
So
I think,
thank you for that.
yeah, I think the last point, like really just to touch back on Krista's point, is that, we think about the community in relation to other actors and forces, right? Like there needs to be political will and funding for some of these things. Communities can't just do everything on their own. And the burden should not be put on communities, but communities have the knowledge and the power and the innovation and the trust, so that they can be agents of change, but they can't do it on their own. I think Ellie had a comment that I'm having trouble reading in the chat. Could someone read it?
Yes, so Allie Chambers, she had mentioned, I think they are the cornerstones of everything we do for our clients. And so honestly reflecting on all the concepts that you all have outlined thus far.
Great.
And I would just even mention while I've got the mic, is, you know, when I, specifically the community resilience piece, I think that's something that we all within the state of Tennessee have been resilient and continue to be resilient and trying to figure out situations to help one another with the recent announcements that we've been focusing on. Like the community as a whole has come together and just sustain and recognize that, you know, we're not all in this alone. Like while we work for different organizations, we're here together.
Thanks, Elizabeth. Very good point. Good. Are there any other comments before we go on? That was great, Krista. That was a really important question. That was helpful.
Ellie, yes, everyone who's contributed, it really helps us understand your perspectives, you know, which is, it's crucial.
Yeah, great. Okay, thank you for that. So now what we'd like to do is show you a little video. It's about 6 minutes that overviews the social determinants of health, and then we'll come back and hear your reactions to the video.
Elizabeth, can you make it full screen?
It's not showing full screen on your end.
No.
Full screen on my end.
Oh, maybe it is. You know what? Maybe it's because I don't have it. Okay, ignore me.
Can you hear it?
Yes. Oh,
No audio.
no,
Okay.
no.
Play.
Is the audio coming through now?
Not yet.
I'm gonna try and pull it up.
I can also try keep you on.
So I'm having trouble getting the audio to come through.
Shall I try it since I don't know, maybe I don't know if it has to do with hosting, but should I could be the third try. Oh.
Elizabeth, now you need to mute your computer. Courtney, will you try and share?
like this.
Can you see it? Let's see.
It's
No,
still not coming through.
Can you see the video though?
Yes. I'm gonna drop the video in the chat.
Okay, you know what? Let me try one time.
Want me to try?
Do you have it queued up, Sarah?
Yeah, hold on. Is it working?
Yeah, it's playing, but we just can't hear the audio.
You can't hear it either.
I think Katie's gonna try.
Okay, sorry. I could hear it, so I thought you could.
And we can't hear it from your end either.
I tried putting the link in YouTube. There's like no sound even in YouTube when you copy the link either.
That's so strange. So sorry, everyone. Because it's
No, I could hear it when I played it, but I couldn't. Apparently, you couldn't. So I don't know. I don't know why.
okay. So maybe we just have to keep going. And people can watch it on their own later.
Yeah. Okay, let's do that then. Thank you.
Okay.
Sorry,
So
everyone.
I'll pull
Because
my slides back up.
okay, great. I was going to ask you what struck you most about the video, except for this really cute music they have, but no one heard it, so I can't ask you. Um, so
Okay.
I
So
I
Sarah, let
think
me
it's,
know if you can see this.
yeah, I can see it. And I was just, yeah, on the next slide, I was going to just ask them. This is basically, just so everyone can see, this is a summary of the video. So they lay out the structural determinants and show that there are also intermediary determinants and that these are not linear. They go back and forth and they impact the health system. Okay. And what we can do maybe is when we share the presentation, you'll have this slide and then everyone can watch the video. But this is basically the summary slide of the video. And then what we wanted to do, and I'll hand over to Courtney, was share with you some of the quotes or discussions that we had with participants in the research we had done in Alabama and Mississippi, and a couple of other articles that were included talking about their experience with these social determinants of health. Courtney, can I
So
hand over to
yes,
you?
yeah. Can you guys hear me? So I don't know why, but my video is not on, and when I try to switch it on, it's not working. So I didn't switch it off, and it's not. I don't know if it's a bandwidth issue, but just know that I. It decided like, okay, let's not do video, but I'm gonna keep going because I don't know what else to do. So, this is research from work that we've done in Alabama and Mississippi. On this slide, we have a number of quotes from participants who are all people living with HIV. And in this slide, they're from Mississippi. And we're wondering if you can point out to us what some of the social determinants of health are that these individuals are battling. So we're a little challenged by the technology, so feel free to shout it out or put it in the chat. Anything is welcome. So what are the social determinants of health that that are in focus here for these participants sharing their stories from Mississippi? What do you think?
Economic stability, the one that don't have funding to get the support services they need.
Absolutely, yeah. So it could be income, economic stability. That's important. Excellent. Other things that stand out?
There is also a message in the chat from Morgan Health Service, so community and social support.
Yeah, social support, very important for people.
Healthcare
So
access, they don't have enough physicians per person.
absolutely. So access to healthcare and to HIV, physicians. Okay, I'm going to move. Excellent. We're going to move on to the next one. So here's another set of quotes, again from Mississippi, about not talking about prevention of HIV, and a quote from an article, not from our research, from the New York Times, from a man in Mississippi. So what comes out here in terms of social determinants that are influencing people's health in Mississippi?
Education.
Absolutely. So education about safe sex, about preventing STIs, HIV. Anything else?
Religious
Social and
values.
community context.
Yeah,
Just having that's your only resource is the church, and it's kind of stigmatizing.
absolutely. Yeah. Anything else? Stigma, lack of information and education, political, social context, like you said.
I think I heard someone say religion. Courtney, someone chimed
Okay.
in.
Yeah. And religion can be enabling, it can support people, and it can be disabling, right? That's very, very variable depending on the context. So moving to this next slide, here we have about 4 different quotes from Alabama that highlight a different social determinant of health. What's coming out for you all in these quotes? This is a big one for many people. So
A
Chastity,
need for coping and a lack thereof.
yeah. Can you just say the first part before coping? I was
I was just
speaking.
saying they all articulate the understandable need for coping with a new diagnosis, and if it's not there, then they are seeking ways to cope, which would not be necessarily the healthiest.
Absolutely. Right. So people, they need the support in order to, really metabolize their status and living with HIV. They're not getting the support, the counseling, and so then they're engaging in substance use, right? And may have issues with mental health as well, right? We see these as being co-located. Yeah. So I just saw one comment. Great. Counseling is needed. No social support. Okay. So then, oh, please go ahead, please.
Yeah, I would say that the lack of nearby adequate medical care probably makes people feel very othered and ostracized. Like I've got a condition that nobody's equipped to treat because it's so uncommon. It's going to make people feel really isolated.
Absolutely. So that's what stigma does, right? Stigma makes people feel isolated and othered, right? And then it can entrench, suicidality or, feelings of lack of support, right? So these issues are connected, and they become very important in people's lives in trying, to manage and trying to cope and try to link to care and stay in care. All right. So when we look to our research in Alabama, we had, it's a relatively small sample, but we had their very in-depth perspectives on challenges they faced. And these are 3 quotes from Alabama. So what's the social determinant that we're seeing that pops out here in common for these people, both in Birmingham and Tuscaloosa?
Disparity.
Can you say that again?
It's food disparity.
Food disparity, perfect. Yes, yes. I do apologize. Outside my window, there's a lot of traffic, so I don't know if you can hear it. But okay, so this next slide I think also accentuates an issue that we've already been talking about that is very prevalent for people living with HIV and you know, regardless of setting. Stigma. Thank you, Robin. Thank you, Elizabeth. Yeah. Yeah, so these are powerful quotes, you know, that highlight stigma that is experienced, you know, stigma that is anticipated or maybe self-stigma as well, you know, for many people. So these different types of stigma are crucial and can be a very important barrier to care, support, and persistent, you know, viral adherence and viral suppression, as we know. Okay. Sara, I'm going to turn it over to you.
So just to complement some of the quotes that Courtney's already shared with you, it was to give you an overview of these intermediary determinants that we saw in the people that we had been working with in Mississippi. And as you can see, 3/4 of them were experiencing stigma, either explicit or perceived stigma. And then you can see many of the social determinants of health here, about 1/4 of them having issues with transportation, food insecurity, almost half of them unemployed. And then you see mental health challenges in the form of bipolar disorder, anxiety, or depression. And then substance use and incarceration, about 50%. And then problems with unstable housing or homelessness in about 1/4. So it's quite interesting. And Courtney, if you click to the next slide, you can see how much these mirror exactly what you are addressing in your own plans for ending HIV and the social determinants that you've already identified. We just thought it was interesting that it so much mirrored the research that was done in Mississippi. Thanks, Courtney.
Okay, so we want to just get some reactions. Like, these are powerful experiences that people shared with us, challenges that they face. You know, what are the quotes that resonate with your work at this time? That's our first question. Our second question is going to be, what interventions do you think are needed to address some of these situations? And are you able to connect your patients or clients with the needed resources or programs? We'd like to do this in breakout groups for about 7 minutes. So Katie and Elizabeth, can we try to do that?
Yep, we are ready to go.
Oops.
Thank you.
All right, I'm going to send everybody to the breakout session, and then I'm going to copy and paste in the discussion topics. So give me just a second.
Great. And as you're going into these breakout groups, you know, these the issues you're facing, you know, with patients, they could be different ones, they could be newer ones. I think as someone mentioned, you know, some newer challenges that have come like during or post COVID. And so you know, those may be examples that you want to raise that we can think through together. And some are the long-standing ones that we know. Ooh, my video came in.
Courtney, I think we have the breakout group and you're muted.
Thank you so much for letting me know. So yeah, my intention was that you could talk, amongst yourselves and it would be more informal than me joining, but I'm
Yes.
happy to join if I'm here. So I'm gonna pass the baton, to you all to just share, some of your thoughts about these questions. Do you want to kick it off for us, Aditya?
So I would love to, but I'm the student who missed that part of the homework when the codes were being shared. So if you could reshare them, then certainly we can take, but other colleagues may already have to
Okay.
kindle the discussion. Yeah.
Yeah, we're just really talking about the quotes right now and which resonated with people. So if there were quotes that resonated, um, does someone want to just share a perspective and connect it to maybe interventions or actions that might be needed to address that challenge?
So there, I'm not sure the quote that where someone, where you and Sarah had asked about what are the social determinants that are lacking that are being highlighted by this quote, where an individual talked about, the 48-year-old individual talked about learning about the diagnosis and how it affected them. If there was part of the pool of quotes, then it resonates with something we have heard from our patients, and one in particular about 12 years back, where a very articulate youth, a very effortlessly and in a unscripted and unrehearsed way, spent 8 minutes and 15 seconds speaking to a recorder about the initial experience of coping with the HIV diagnosis and how it sort of he hit bottom, and then him cutting himself, and then seeing the color of his blood, and then asking the question, it's still red, why is it different? And then from there picking up and then getting information about HIV, with that building own self-resilience and confidence, and then ending on a note of, once you are empowered with education, you can pretty much do what you want. So I share that as a reflection, and also colleagues who are from St. Jude know this, but for others, this 8-minute and 15-second recording was part of the start of our program, starting to collect, just like StoryCorps, recordings, such that those recordings can then become accessible to future patients. And so in that slide, there was a mention about not having access to support groups. So these recordings become like a virtual support group, which can be accessed, and you can have join someone virtually by just hitting play.
That's excellent. I think that's such a great example to highlight, how people struggle to cope. They struggle to break out of, loneliness and to make sense of their diagnosis, right? And they can use these different mechanisms that don't have to be expensive, like recording oneself. And these are things that can make a real difference to people processing their experience, right? So thank you so much for sharing that example. Is there anyone else who would want to just share a challenge that they've seen in their patients and programs that might be helpful, or even the lack of programming, where the gap is that you're seeing?
I think
Right.
a lot of people got cut when they were talking because this was really good conversations. So we might just want to take a minute to let people finish their thought. And I also wanted to ask Kelly, who was talking in the group I was in, who you're working with, because you referenced your group and I didn't know the context. So I would just be curious to know, because the conversation was very interesting.
Yeah.
You mean what agency I work with?
Yeah, are you working with a CBO? Are you working with patients? I wasn't clear from your
We
comment.
work with patients. So I work for Friends for All. We work with patients. We are on the preventive and treatment side.
Kelly, not to put you on the spot, but I'm about to.
Of course you just did.
Do you feel like sharing what you had shared with your group?
Well, we were just talking about the particular quote that we just kind of were discussing was the one where the client gets the diagnosis and they're not really processing it, but they may return to maladaptive behaviors, including substance use, and they're not really linked or connected to care, or staying with it, should I say. And I know we've had instances where our prevention team has connected or attempted to connect them with this, but we are operating on like a 8:30 to 5 business hour, Monday through Friday, in our main building. And so sometimes there's a lapse in between them getting tested or them meeting with our prevention team in the field and them getting back to us during our business hours for us to connect them to care. And so we were just looking at that as one of the barriers that we've seen and run into. I think that's where we got kind of cut off. We didn't get to the solution side of that.
Well, there are so many, well versed and experienced colleagues that are on this meeting right now. I wonder if anyone else could think about ways of addressing, those issues that they have, used with their own patients. Are there any sort of innovative responses that, that people would want to put forward?
Well, we were talking in a group that we kind of got cut off. I'm Andrea, by the way. I'm with Friends for All as well. One of the solutions that I was kind of talking about was the fact that me being a therapist and me being on the prevention team and being out there in the field, when we do those tests that are out in the field, it helps because I'm the one doing the test. So I'm the one giving you your results, and I'm also a therapist. So when I see that that's going in a negative way, I'm able to jump in at that moment to give you kind of like an emergency session there to bring you back in and then connect you to further services with Kelly when they're back in the office. But me being in the field with the team and being able to handle that immediate need right there helps to kind of bridge that gap until they can get to office hours and see another one of our providers about those mental health needs. And that can help stem, those maladaptive methods, because if I can give you just a small piece of help now, we can come up with a plan and a step to get you to Monday or get you to the next day when office hours open at 8 o'clock. And that's work
Absolutely.
for us.
Oh, yeah. This is powerful because, Andrea, not only are you providing the counseling and support that's needed in the moment, so you have the knowledge and skills, but you're also going out into the community, which reduces a barrier in terms of travel or getting oneself together, to go to a clinical or a community-based setting, right? So it's really innovative and responsive, and important to address those needs in the way that you are doing in this example. Thank you.
May I add something?
Absolutely.
One of the other things we didn't get to get to on that breakout was that when she's able to do that, one of the other things that we can see is helpful is the constant presence out there in a community like that, because they see some of the same faces. And so maybe if at that initial meeting point, if I don't know, the client needed a little bit more repetition or a little bit more encouragement to get to that next step, they're seeing the same faces out there in the community, and so they're able to connect with those folks and get what additional support they need before they are before they are ever able to get back to us on the during the regular business hours. They're able to see those same faces out in the community, and that creates a sense of continuity with us as well before they even get to our doorsteps.
Yeah, Kelly, I'm so glad that you mentioned that, because all of our experience and the research says that people living with HIV, they want to have a provider, a professional who they can trust with their stories, their experiences, right? And not only is there that continuity, but it's also showing the care of those individuals and building that relationship, with patients, which it's fundamental, for people in their care. So I think it's a really excellent example of how that sort of continuous care can be established, by providers with patients in caring consistent ways, which really matter to people's lives.
Yeah, I know that Miss Hawkins has her hand up. I don't know if you can see, so I'm just
I can't see it.
pulling
Okay. Oh, yeah,
Yes.
please go ahead.
Thank you. I actually work for Sister Reach, which is a community-based organization. So we don't have providers on staff. However, we do refer our clients out, and piggybacking on what Kelly said, it is the report, it is the continual presence, it is the testing in the community, it is meeting the need. Whether it's a food pantry, whether it's a safe sex kit, um, even to the point of providing unused syringes. Like, it is being in the trenches and being in the cracks and the crevices where people see you continuously. You may see me every week, sometimes twice a week, but it's also being able, as a community-based organization, be able to provide a linkage to care to providers that we trust, we know, we have relationship with, where I can pick up the phone and speak with a case manager and say, hey, I have a person that I need to send. And it's bridging the gap when a service recipient see that you trust the provider, that you are able to speak to a provider. You're not just throwing them off or into a space and it's like, figure it out. But there is a relationship and a follow through that's happening. They're more likely um, to continue with the care, even if continuing with care is coming back to Sister Reach to utilize our food and clothes pantry for those moments. If whatever the outsourced resource is, we do our best to stand in the gap and send them to places and people that we formed relationships with, and that tends to um, sometimes break down the barriers uh, that our people, encounter throughout the process.
That's wonderful. Yeah, what comes roaring into focus, Kiunda, is just the relationship centered approach. That it is about those relationships, right? That you're really putting front and center in all the examples that you gave, and working tremendously hard to do that. So these are really important, lessons for all of us to remember in terms of, what makes the difference.
In the Courtney, in the initial group I was in that we got cut off. I'm sorry,
Oh.
Lauren. We got cut off when we first started talking. That was also a discussion is what is the training of the person giving the diagnosis? Because we were talking about this key moment. And this issue of trust is so important. And also I heard some comments about whether, as Kelly is also a therapist, whether these people are actually trained, because I think this also fits into our discussion around stigma and what they're feeling at that time of diagnosis. And I know from Courtney and I's research in Alabama, when we talked about where people drop off from the continuum of care, that point of diagnosis was a huge issue. And it had a lot to do with the training or lack of sensitivity and training of the person giving the diagnosis. And I think you have all touched on that in the short conversations I heard. That was really a large part of the discussion.
Yeah, well stated, Sarah. So these
Yeah,
are
and I don't know if anyone wanted to add, Courtney, sorry, because we got cut off. I don't know if Lauren and Nikita, there was something you also wanted to bring back to the discussion because we were stopped. So sorry, Court.
Oh,
One thing we've done kind of with my role is I do testing out at the needle exchanges and in the community. I've also EIS now and prep navigation, so we have a status neutral approach to where if someone comes up to me needing any type of service, whether they're HIV positive or HIV negative, I have food bags that I take out there with me with survival kits that anyone can get, and it starts conversations about PrEP, PEP, what resources do you need? So if anybody comes up to me, they can't say, oh, that person has HIV, they're talking to him. You don't know why they're talking to me. It could be PrEP, it could be PEP, it could be a food bag, it could be housing. I've created resource guides and stuff like that to where it breaks the barriers down where anybody can come talk to me at an event. And I'm at the same events so where, I'm serving food on Friday nights and they may be coming to me for another plate of food. It lets them start having those conversations with me about other things, substance use disorder, and having those other doors open gives people an excuse to talk to you without the community seeing them and being able to stigmatize them. And having the EIS training and doing that, when I do have a positive, I can right there, like 30 minutes, I can do presumptive brown white and set up their appointments. We have our clinic. I can just connect to some Wi-Fi and I can, before they leave me, hey, you got an appointment Monday, I'll be there. I can walk you through that. And that helps to start establishing that trust. The issues, of course, like if it's after 7 o'clock, and they get a diagnosis like that and they're living in a homeless camp out there, I have nowhere I can get them. After 7 o'clock, the shelters don't let people in after 7. And then, of course, technology, cell phones, stuff like that. How am I going to get a hold of them? I have to try to drive around and find them when it's the time for appointments, stuff like that. But yeah, establishing that trust in that same spot every week that we go to, like I'll see them the next Friday, like, hey, how are you doing? You missed your appointment. You want to reschedule? They know where to find me. Yeah, that helps.
thank you so much, David, for sharing those examples. It's powerful. That's just simply stated, powerful. Are there any others that want to share experiences, examples, challenges, innovations? Sarah, should we move on to community resilience?
Sure.
Okay, so
So
I'm gonna
thank you
close.
for,
I want to thank everyone who contributed, you know, verbally or in the chat, and also in your groups as well. I know it's probably just a slice of the broader conversations, and we got cut off because it's hard to manage all the time dynamics, and again, WebEx is new for us. But thank you all so much. Okay, I'm going to share my screen. And
thank you. And I also want to express my respect and admiration for all the work that you're doing.
oh,
I think,
absolutely.
as Courtney said, it's very powerful, and it's really an opportunity for us to get to speak with you and learn from you and listening to you. And I think when we do this again, we might do fewer slides and have more time for discussion, because I feel like really we were just starting, or in your groups, you were also really just starting some important discussions about linkages to care, which is, I think, the point, and kind of reflects all of the key concepts that Courtney and I were trying to raise today.
Sarah, on this point, before you move along with community resilience, I think it could be wonderful just to have individuals share their experiences and lessons learned in this way, where it's a whole, you know, hour, or maybe, you know, hour and change, because I think tapping the lessons and expertise of others, you know, for problem solving and sharing, I think it would be excellent, right? Excellent.
I
So
think
it's,
Courtney's asking if you guys would be willing to do a research group with us, right?
well, but also, no, really, even if we're not involved, you know, if someone else is facilitating, the knowledge is within individuals, right? And the skills, the expertise, it's there. So it's just about like tapping it and bringing it to the surface and sharing it. You know, whether we're involved or not. I think it would be fantastic. So, okay, back to you, Sarah.
Okay, thank you. So I feel a little bit guilty closing that conversation, but we'll continue it. And I think maybe what we'll do, Katie, is not try to do another breakout group, because we don't have much time left, but I'll introduce a little bit more on community resilience, and then maybe we can talk in plenary together instead of breaking out and coming back, if that's okay for everyone. I mean, I think this is obviously, you are all working to strengthen community resilience, and in strengthening community resilience, you have to address the social determinants of health. I brought along my rubber band here to introduce the concept of resilience, just this idea of an object that springs back right into shape, and about a bit its elasticity, because resilience is a word that has been used obviously in other fields. Comes from physics, mathematics. It's used in psychology, especially around child psychology, and then more recently in ecology, and then in my own field of international development, and then in disaster risk management, dealing mainly with natural disasters, and then in health. And notably, the concepts around concept resilience came to health in light of the Ebola crisis in West Africa in 2014. And of course, community resilience has been re-examined in connection with COVID as well. And why the community level? I think because of you guys, right? Because focusing on the community and building resilience requires local context and knowledge in order to address things that are changing in your own environment. Okay, so next slide, Courtney, it's fine. Thank you. So community resilience is a process. It deals with how you react, adapt, and then transform. And this is what we touched on a bit earlier in the conversation about looking at some of those structural injustices. And the idea is that if you can address social determinants of health and strengthening your community resilience, then you can address some of those structural issues for the better, right? So a resilient community is one that can use its capacities to mitigate harm, to react, and to grow in light of a challenge. These are some general definitions. There's some more in the resource material, but I wanted to look a bit at the key concepts that are involved in community resilience. That's on the next slide, Courtney. So you will recognize many of these. They are also repetitive of some of the discussions we've had around social justice and equity. that these are key components you need to actually mitigate these vulnerabilities. And to address these, you have to be looking at social determinants of health. Here I highlighted governance and ownership because I think this is a key point in discussing how communities are strengthened, which is that you have to be part of this decision making and the policies that are developed. So as you've reflected your own experience in your End HIV and the 901, I mean, this is the same idea. It's bringing your experiences into the reactions and the policies that are made to strengthen your communities. And of course, there are aspects here to mental health and physical health. Just for your own information, the discussions since Ebola have really pushed to look at this public good concept, to have health as a global public good, to recognize the role of all different actors and the strength of that community engagement in reactions and strengthening resilience. And then since COVID, there's been a lot of discussion around decision-making technology and information. And David, I saw your point in the chat about technology and how much more important that has become in light of COVID and the fact that we're not always physically together. And I think that is reflected in the discussions around community resilience and strengthening that resilience. But looking at the list, I also wanted to ask if there were other components that you don't see here that you think are important. Or if, you know, for you, these seem to resonate and make sense, or if there's some that you think might be missing. No? You can comment in the
That
chat
it's
as
not
well. Yep, please.
not just about access. Also, it's also kind of about ease of access and, like David said, taking it to where the people that need it are to increase that ease of access.
Absolutely. Absolutely. And
Representation with your access too. Do they speak your language? Do they look like you? Is it an inviting environment?
exactly, that's a very good point. That in the languages, the communication material, how you communicate, what kind of information you're sharing, how you share that information. And I think, David, you also touched on this social cohesion aspect, you know, the trust between the people you are working and communicating with. It's great. Any others? No. Okay. I mean, they can come up. So, Courtney, if you don't mind going to the next slide. What we had wanted to do was learn a little bit about your experience during the pandemic, thinking about this approach of community resilience. And maybe we won't do it in breakout, so maybe it would be nice to just take a minute to jot down what you think are the functions that are vital to your community, to your patients, and what you did to address any changes in those functions or interruptions during the pandemic. You know, because I'm sure some things changed for you, but just thinking about what is key, how that was addressed, and then what social determinants of health are involved in that. What's at play in that? So maybe I give you a couple of minutes to think or note those down, and then we could open for a short discussion before we wrap up. Unfortunately, we won't have time to do this in groups, but maybe next time.
I can speak for my organization with in Memphis.
Great, thanks,
There were
Megan.
drastic changes to the public transportation system. Bus routes were reduced by 20%. And of course, food costs went up, just need went up. And so we met that need by starting food pantry delivery. And we have continued to do that because we've seen that the need continues, you know, after the pandemic and after people are still out, we have people who really needed that delivery service. And we saw that it met more than just transportation need. It also addressed stigma. We've got folks that they prefer to have food delivered to them because they feel that, you know, walking into our building identifies them as someone with HIV. So it's met a lot of different needs, I think.
Thank you. Yeah, that covers, yeah, exactly. Some very basic, important determinants, right? Transportation and food. And I think what you said is interesting because I think in a lot of cases there is some continuity to things that were put in place during COVID that might stay with us even beyond.
But what I like about Becky's response is also saying, okay, there were these greater challenges to overcome during COVID, and what were some of the innovations that were put in place that then could either be extended, beyond the pandemic, or helping us think about other innovative responses, right? That might be helpful to address gaps, some of which have been mentioned, today.
Thanks, Court. Do others want to come in?
In that same vein, at Friends for All, our outreach center is the Haven. People couldn't come to us, so we took home test kits, HIV home test kits to them, and we would do a consent form with them, an intake form, and then we used telehealth, so they wouldn't have to do the test by themselves. So they wouldn't have to get a result, negative or positive, alone, and that way we could link them to care as it was needed. And sometimes we still give out home tests in case people need them or they feel more comfortable doing it in complete privacy.
And Krista, did that work well?
It did. Getting the word out about the home test kits was kind of tough because a lot of information gets around word of mouth. And during the pandemic, we were all so shut down. We would put it on our website, we would put it on social media. We told as many people as we could, but we had a lot of people asking us for it. And when we felt like it was safe to do, we would take the kit, and we would meet them somewhere in a public space and hand them the kit and talk to them about the telehealth.
Thank you for that.
Sounds superb. Yeah, and telehealth has been such a game changer, for people living with HIV.
And I just want to comment on, I think what everybody has said so far, the main thing for me is the innovation. Communities becoming more innovative of how they're going to reach patients, how they're going to reach clients, and how they're going to continue to provide these services to clients, whether that's meeting them where they are for HIV testing, or if that's bringing their food to them, or even the other things that picked up, of course, medication delivery. It's been around, but it was it increased, during the pandemic. And I think the cool thing is just as the community evolves and we're now 3 years past, or 3 years, out, is, continuing these innovations that people are continuing to realize, meeting people where they are, or agencies, or, the work that we do, meeting individuals where they are and in the comfort of their own space, whether that's their physical space or if that's their emotional space, or whatever the space that they need, meeting them in the situation so that way they feel more comfortable and more apt to breaking down those walls that they have internally.
Yeah, like you're
Sure,
saying,
yeah.
Elizabeth, what's striking too is if people have mental health issues, or substance, use issues, going to them is going to make it much easier for them than for them having, to go to, to a clinical setting or to a CBO setting, right? So it is overcoming a range of barriers for that overcome also challenges that people may be facing in the moment, or longer term.
Anyone else want to come in and comment some of your experiences? No, I just didn't want to cut anyone off because we have a couple minutes before we wrap up.
I have trouble controlling the PowerPoint.
A lot of the places that were doing testing had shut down. We did a lot of testing. We found out like we could do it outdoors as long as we had a tent. So there's a couple of places we set up. We actually had great testing numbers in the middle of the pandemic because it just wasn't very readily available. We still do a lot of testing like that, just kind of setting up in places where people already are or already have to be. We've kind of transitioned more to that instead of doing testing. We do offer testing in our office, but for the most part, we do outreach. We never we never got away from that since we started doing that in the middle of the pandemic. It's just like we just learned very quickly people are going to be more willing to take a test if you're already at an event or a store that they have to go to anyways. Between that and the corner started offering telehealth because they could only see somebody once every hour, which made it difficult to get people in for PEP, and do HIV initials. So actually, as a result of us having issues going and getting appointments, the corner started doing rapid start HIV medication. And we were able to start doing telehealth through them. And even in the middle of it, we were contracting out through AEL. We would do telehealth and then use another lab to have people go into to give more flexibility to help people get into care and connect to care. But like you really, ironically, the pandemic really helped us to really establish ourselves in the community. We had to get out there. We couldn't do it in the office.
It's fantastic. Just like you've mentioned the frequency, right? And the ease of access, which can be so important, are, you're providing that. Going to people rather than having them come to you in the sense of, behind the clinic, in the clinic walls or in the community, setting, being out there and making it available is excellent.
Yeah, thank you for sharing that. Anyone else want to come in before we wrap up? No? Okay. Well, thank you for the discussion. I mean, for us,
Yeah,
this
we
is
could have
very
kept going.
interesting. Yeah. Yes, absolutely. Okay, I'll hand the floor back to Courtney.
We're just mindful of our time contract with you all, and really grateful for this opportunity to be together. So the last two slides are just coming back to, these were our key messages that we flashed on earlier about social determinants of health, being modifiable. And moving beyond this traditional historical biomedical approach to recognize these social factors that influence people's opportunities to be healthy, in order to advance health equity. And thinking about recognizing health as a public good that's available to all, with community resilience being one approach that really allows us to address social determinants of health at the local, national level in order to improve outcomes for people living with HIV. And so another way to think about this is just that, ending HIV requires the policies and the practice that are grounded, located within human rights-based approaches that recognize and address these determinants to advance health equity, recognizing the human dignity of our patients, of individuals, and really fostering health as a core value and a public good. So thank you all so very much for being with us. Thank you.
Thank you. It was very nice to meet and talk with you all today.
Yeah, we really appreciate your sharing your experiences, your expertise, your knowledge so much, and for being with us. And thanks again to St. Jude, colleagues there. Thanks so much.
Oh yeah, wonderful support, really.
Yeah.
Thank you both so much for such a great presentation. We've got a lot of comments floating in saying thank you and great information that was shared, great content. And so thank you all for your active participation. We greatly appreciate it. Again, if you all, I didn't see anybody request the slides, but that is something that we can, if Courtney and Sara, you guys are okay with, we can definitely share that information. I'll transpose it into a PDF and get that out. Also, the recording will be shared as well. And then they did mention that they were planning on sending some resource. Okay, I do see you, Chastity. A resource list that we'll also send out as well, just for follow-up information, as well as different resources on the content that they presented on today. So again, I thank you. We're about a minute over, so I'm not going to keep you any longer. So thank you so much for your time. And in that resource, the presentation will be shared sure to include both Sarah and Courtney's information with you. So without further ado, thank you all. Have a great rest of your day. And thank you.
Thank you.
Thank you
Katie,
so
you
much.
can stop the
Bye,
recording.
take care, everyone.